This video will cover the importance of nutrition in sick patients, the supporting evidence, and how to treat and prevent malnutrition. We will also discuss the routes for feeding, the types of tubes used, calculations, and the risks of refeeding syndrome. As Hippocrates stated in 400 BC, a restricted diet can be dangerous in both chronic and acute diseases. Dr. Mike Stroud emphasized the need to avoid starving patients and to provide nutrition support using the safest, simplest, and most effective route. Nutrition is important because malnutrition is common in hospitalized patients, often deteriorating during their stay, which comes with significant costs. Critically ill patients are frequently malnourished due to various pre-existing conditions and circumstances. The metabolic response to starvation aims to conserve energy and minimize the impact on vital organs. This involves a reduction in tissue metabolism, decreased metabolic rate and temperature, and reduced physical activity, leading to protein loss. In the ICU, complex metabolic changes occur, leading to high weight loss, even with feeding. Nutrients may not be adequately absorbed or metabolized. Severe catabolism, poor wound healing, and insulin resistance are common. Therefore, feeding must be tailored to individual needs. ICU nutrition has evolved from using mixed-up feeds given via NG tubes, which posed infection risks. Now specialized feeds in sterile packaging are used. Risk assessment tools like the Nutrix score and NRS 2002 are used to evaluate nutritional risk in patients. Evidence in the HDU shows that early nutrition is crucial, and the gut should be used if possible, as bowel function may recover quickly. Preoperative sugary drinks can speed up bowel function. Use both enteral and total parenteral nutrition to meet goals. Who is responsible for treating and preventing malnutrition? It is a team effort. Doctors and nurses identify malnutrition through history, weight loss, and intake assessment. Nurses optimize oral intake. Doctors, dietitians, and nurses manage enteral or parenteral feeding, and monitoring is done collaboratively. The Malnutrition Universal Screening Tool, or MUST, from BAPEN, uses BMI, weight loss, and acute disease effect scores to determine the risk of malnutrition. High-risk patients require early treatment. According to NICE guidelines, patients are at risk if they have eaten little or nothing for 5 days and are unlikely to do so for the next 5. They are also at risk with poor absorption, high nutrient losses, or increased nutritional needs. A patient is considered malnourished with a BMI under 18.5 or weight loss over 10% in the last 3 to 6 months. Also, a BMI under 20 with unintentional weight loss exceeding 5% in the last 3 to 6 months indicates malnutrition. Weighing patients is essential for accurate nutrition screening, drug dosage, cardiac output monitoring, fluid balance, and CT scanning. Enteral feeding is the preferred route. It preserves intestinal mucosal structure and function, is more physiological, and reduces the risk of infectious complications. Nasogastric feeding in the ICU carries aspiration risks. Therefore, the head of the bed should be elevated to 30 degrees. Starting feeds at night should be avoided. Gastrostomy feeding is used for long-term needs. Jejunal feeding involves placing a tube into the jejunum. This can reduce the incidence of aspiration and often allows for a higher dose of enteral nutrition compared to NG feeding. We use total parenteral nutrition, or TPN, when the GI tract is not functional, cannot be accessed, or when GI feeding is inadequate. If enteral feeding is not sufficient, TPN can be started after optimizing enteral nutrition, typically between day 3 and 7, depending on the patient's nutritional status. When TPN is needed, a doctor orders it, a dietitian decides the regime, and pharmacy prepares the sterile bag. Feeding starts low and builds up while monitoring bloods. For TPN access in the ICU, a central line is usually used, and a clean port should be reserved. Strict asepsis must be observed, especially when handling long-term TPN lines like Hickman catheters or subcutaneous ports. The various tubes and lines are vital for nutritional support in critically ill patients. Complications of feeding include constipation and diarrhea. Intolerance may suggest sepsis. Prokinetics, NJ feeding, or other drugs may be used. Line sepsis is a serious risk. Ileus can be managed by avoiding opioids and optimizing fluid and electrolyte balance. Overfeeding can lead to complications such as lactic acidosis, hyperglycemia, increased infections, and liver impairment. Persistent pyrexia may also be a sign of overfeeding. Nutrition prescription is calculated by a dietitian using equations like Schofield, adding activity and stress factors. For example, A 65 kilograms ventilated woman with sepsis may require around 25 kilocalories per kilogram/24 HR. A rough starting guide is 25 kilocalories per kilogram per day, increasing to 30 as the patient improves. Aim for 1.25 grams of protein per kilogram daily. Fluid needs are about 30 milliliters per kilogram/24 hours, plus extra for fever or excess losses. Avoid overfeeding, especially in obese patients. Refeeding syndrome is a potentially fatal shift in fluids and electrolytes in malnourished patients upon refeeding. As metabolism shifts to glucose, phosphate, potassium, and magnesium move into cells due to anabolism and insulin release, causing severe drops in blood levels. This can lead to extracellular fluid expansion and thiamine deficiency.